talking a lot about STEMIs and myocardial infarctions and ischemia and injury, but let's talk acute coronary syndromes. Acute coronary syndromes come in three main classes. In all of these conditions, we've got ischemia of the myocardium, and they haven't quite led to complete um, irreversible cell death. So, our three classes: unstable angina or angina, depending on where in the country you live. So, unstable angina, non ST segment elevation, myocardial infarction or NSTEMI, and also ST segment elevation, myocardial infarctions are STEMIs. So we've already talked about STEMIs. So now let's kind of shift a little bit and talk about unstable angina and NSTEMIs. Unstable angina, this is just chest pain, but it's chest pain at rest. So I've got chest pain maybe with exertion, but when I take a rest, it doesn't go away. Or maybe I've got this like crescendo, decrescendo pattern. It comes and goes at rest. So the big delineation here with stable versus unstable angina is I've got chest pain, but when I take a rest, when I sit down, it doesn't go away. It keeps on coming. I might have some shortness of breath with this. I might have some diaphoresis with this. I might have some nausea, vomiting with this. And when you take a 12 lead, it might be normal, or you might have a little bit of ischemia, a little bit of ST segment depression or flipped T waves on your 12 lead. And with unstable angina, if we were to draw labs right then and there, we would see our cardiac markers, our cardiac labs, they would be negative. So this is chest pain, but at rest it doesn't go away. I might see some ischemia on the 12 lead, but my cardiac labs are negative. We've talked about our ST elevation MIs or STEMIs, so now let's talk about our non-ST elevation MIs, our NSTEMIs. Because your patient may still be having a heart attack. It just might not show up on your 12 lead. So your 12 lead picking up a heart attack in terms of a STEMI is like a 50-50 shot, give or take. So your patient may still be having a cardiac event, may still be infarcting. They just might not have an ST elevation MI. They might have an NSTEMI, a non-ST elevation MI. So this severe ischemic state, this infarction state, injury state, typical signs, symptoms of an MI: chest pain, diaphoresis, nausea, vomiting, maybe some shortness of breath, maybe some, dizziness. But when we take our 12 lead, doesn't show any elevation, might show some ST segment depression, might show some T wave inversion, some flip T waves, but we just don't have any ST elevation. So our NSTEMI, we have to confirm with lab tests. And our lab values are going to come back positive for cardiac cell damage. NSTEMI, or non-ST elevation MI, has no ST elevation on her 12 lead. Kind of, well, obviously that's in the name, non-ST elevation MI. How we diagnose this is through lab values. We're going to see abnormal cardiac enzymes, and we're going to look at a few, and we're going to focus on a few. CK, kind of, sort of. We'll hit that in a minute. CKMB and our troponin. And what our NSTEMIs are a partial blockage of a vessel. Not a complete blockage, not a mostly big blockage, but like a little partial blockage. But these NSTEMIs have a very high risk of progressing to an ST elevation MI. Have a very high risk to progressing to the STEMI, and this bigger blockage, this complete blockage of a vessel. So we still have to take it very seriously. This isn't like a mini STEMI. This is a pre-STEMI, if you want to think of it that way. NSTEMIs are found via cardiac markers, lab values. So we're looking at myoglobin, we're looking at CK, CKMB, looking at troponins, and all of these are maybe specific to cardiac muscle, maybe not specific to cardiac muscle, but they peak at different points. Myoglobin, that's kind of an older marker. We don't really look at that much anymore. CK, CKMB, we definitely are going to look at. Our CK is just muscle damage anywhere in your body, just kind of just muscle damage. So if I'm out of shape, I'm gonna go out and like run 3 miles and come home. If you drew my CK tomorrow after doing that, my CK is gonna be elevated because I just like damaged a whole bunch of muscle because I'm out of shape and I just ran 3 miles. So we might draw CK, but that's just muscle, like just kind of generally generic muscle. Our CKMB is our cardiac muscle. So if I damage my cardiac muscle, CKMB will be elevated. Same thing with troponin. Troponin is very specific to cardiac muscle. So if I damage my cardiac muscle, if I injure my cardiac muscle, my CKMB and my troponin are both going to be elevated. And I'm focusing on CKMB, I'm focusing on troponin, and they're different troponins. Troponin there are different peaks to where these enzymes after the event. So since the injury, where do these peak? And with troponin, we're going to get a troponin. We want to find the troponin peak. We want to see the troponin trend. So, every 3 to 6 hours, we're measuring troponin, and we're seeing if the troponin is going up, if it's going down. So if it's trending up, if our troponin is trending up, we still have active damage. We need to do something right now. If our troponin is elevated but is trending down, damage has already occurred. Our NSTEMI is over, and we just need some aftercare, right? So troponin is typically what we focus on because troponin tells us active or non-active. That the trend, I should say, gives us active or non-active injury to cardiac muscle in the moment. What should these be? Basically, anything greater than 0 is kind of an issue. So we're focusing on troponin, we're focusing on CKMB. Our troponin, we've got troponin I, troponin T. Either of those really greater than 0 is an abnormal finding, and then we're going to look for a trend. We're going to measure those multiple times and see if it's trending up, trending down, and is it greater than 0 and trending up? Is it greater than 0 and trending down? And when did that event occur, that cardiac event occur? Is it ongoing? Is it not ongoing? Do we need to act now? Or can we wait till, let's say, the morning for a cath? Same thing with our CKMB. Basically, anything greater than 0 for a CKMB is going to be abnormal. A little bit different than troponin. We're not going to trend those, but anything greater than 0, abnormal. Our myoglobin, don't really, take those into account anymore, but just knowing that our myoglobin, a little bit different between males and females. Males have a little bit more myoglobin normally than females, but we're focusing on troponin, we're focusing on CKMB. CKMB is high, that sounds some alert bells. Our troponin is high, that sounds some alert bells for our NSTEMIs. And then we're going to trend our troponin. We're going to draw those multiple times, see if it's trending up, see if it's trending down. We're going to try to isolate the peak of our troponin, and the peak of our troponin tells us when that cardiac event kind of happened, peaked, and then ended. If you have any questions about all of this stuff, please reach out and let me know.